Welcome to our video on syncope. Let's begin. Here's a slide reminding us of the sequence that we will use while describing syncope. Syncope is the loss of consciousness due to decreased cerebral perfusion. Regardless of the exact initial mechanism, syncope is always caused by decreased cerebral perfusion. Examples of decreased blood volume, that is hypovolemia, include diarrhea, vomiting, intensive perspiration, and bleeding. Hypovolemia decreases the intravascular volume, resulting in decreased venous return, decreased cerebral perfusion, and syncope. Vagus nerve activation occurs in vasovagal syncope. Vagus nerve overactivity results in low heart rate, decreased cardiac output, and decreased cerebral perfusion, inducing syncope. Finally, the patient may have hypersensitive carotid sinus. External pressure on the carotid sinus activates vagus nerve. Vagus nerve activation decreases heart rate, cardiac output, and cerebral perfusion, inducing syncope. Autonomic neuropathy, tachyarrhythmias, and bradyarrhythmias can also trigger syncope. Examples of diseases accompanied by autonomic neuropathy include diabetes mellitus and Parkinson's disease. Patients with autonomic neuropathy have insufficient venoconstriction while standing up. Therefore, there is a decrease in venous return, cardiac output, and cerebral perfusion, which induces syncope. Tachyarrhythmias include ventricular tachycardia and fibrillation and supraventricular tachycardia. Increased heart rate decreases ventricular diastolic filling, cardiac output, and cerebral perfusion, inducing syncope. Finally, sick sinus syndrome, sinus bradycardia, and AV block can also result in syncope. Decreased heart rate decreases cardiac output and cerebral perfusion, inducing syncope. Let's discuss the clinical presentation of the various causes of syncope. Hypovolemia signifies decreased intravascular volume. A person who has syncope due to hypovolemia may also have sunken eyes, dry skin, and mucous membranes. Skin turgor is also decreased, which results in skin tenting. Here you see skin tenting. When the skin is pinched, normally it comes back to its original position in no time. However, in the case of volume depletion, it takes time to restore to its normal shape. Vasovagal syncope is commonly triggered by stress or prolonged standing. It presents with the prodromal diaphoresis, warmth, nausea, and pallor. After the vasovagal syncope, the patients experience rapid regain of consciousness. Carotid hypersensitivity is another cause of syncope. It presents with sudden onset syncope with tactile stimulation of carotid sinus. This can happen with shaving or due to the tight collar around the neck. Patients experience rapid regain of consciousness. A 36-year-old man comes to the physician due to 2 episodes of fainting for the past month. Both episodes occurred when he was shaving. He cannot wear a necktie because it makes him feel dizzy. What is the most likely pathophysiology of loss of consciousness in this patient? This patient had 2 episodes of fainting, and both episodes occurred when he was shaving. Additionally, he cannot wear a necktie because it makes him feel dizzy. These findings are consistent with the diagnosis of syncope due to carotid sinus hypersensitivity. In this condition, carotid sinus baroreceptors are hypersensitive to external pressure on the neck, such as necktie or tight collar. So when external pressure is applied to carotid sinus, the vagus nerve gets overactive and it decreases the heart rate. Decreased heart rate lowers the cardiac output and cerebral perfusion, resulting in syncope. Let's talk about autonomic neuropathy now. Syncope due to autonomic neuropathy occurs while rapidly standing from supine or seated position. Other signs of underlying condition are usually present as well. These may include hyperglycemia in diabetes mellitus or motor deficits in Parkinson's disease. Tachyarrhythmias can also induce syncope. They are commonly accompanied by palpitations. Cardiogenic syncope due to tachyarrhythmias have a sudden onset with no warning signs or symptoms. Additionally, the patients will have the ECG abnormalities specific to the arrhythmia. Finally, bradyarrhythmias can also cause syncope. Patients experiencing syncope due to bradyarrhythmias commonly have pre-existing fatigue and dyspnea on exertion. They may also complain of palpitations and the prodrome with lightheadedness. Additionally, ECG will show characteristic abnormalities such as sinus arrest, sinus block, dropped QRS complexes, and so on. Diagnosis of syncope depends on the suspected etiology. If hypovolemia is the likely cause of syncope, vital signs measurement will reveal hypotension and tachycardia. Vasovagal syncope is mostly diagnosed clinically, but we can use upright tilt table test in uncertain cases. During this test, the patient first lies supine, strapped on the bed for 5 minutes. Then he or she is tilted to the vertical position and maintained in this position for 5 to 45 minutes. We want to identify if prolonged standing induces pre-syncope or syncope in this patient. Carotid hypersensitivity is diagnosed by considering the patient history and observing the syncope during carotid massage. If syncope is likely caused by autonomic neuropathy, then we need the history, physical exam, and blood glucose measurement to make the diagnosis. Finally, both tachyarrhythmias and bradyarrhythmias are diagnosed with ECG. We will observe the ECG signs characteristic of different types of arrhythmias. These may include wide QRS complexes in ventricular tachycardia, fibrillatory waves in ventricular fibrillation, sinus block in sick sinus syndrome, and so on. Let's talk about the management of syncope. Again, management depends on specific cause of syncope. Hypovolemia is treated with fluid resuscitation. Vasovagal syncope is managed with avoidance of triggers and counter pressure techniques like crossing the legs, arm tensing, or squeezing the rubber ball with the hand. Patients with carotid hypersensitivity should also avoid the triggers. If the syncope is caused by autonomic neuropathy, then we should treat the underlying conditions like diabetes mellitus or Parkinson's disease. Finally, arrhythmias are treated with antiarrhythmic medications. Synchronized and unsynchronized cardioversion might be necessary in select patients with hemodynamic instability. Here we see the summary of the causes of syncope. Pause the video and take a moment to consider this table. A 55-year-old woman comes to the physician reporting 3 episodes of fainting for the last 4 months. Her past medical history includes Hashimoto thyroiditis for 20 years, type 2 diabetes mellitus for 2 years, and paroxysmal supraventricular tachycardia self-treated with carotid sinus massage. Her fainting episodes have no precipitating factor but are preceded by lightheadedness and fatigue. The physical exam reveals dry skin and brittle hair and nails. Resting ECG shows no abnormalities. Her vital signs include blood pressure of 120/80, heart rate of 48, and a respiratory rate of 14 in the supine position. When she stands up, her blood pressure becomes 115/78 and the heart rate increases to 65 beats per minute, but she does not feel dizzy. Her TSH is 10. Which of the following is the most likely causes of occasional loss of consciousness in this patient? A. Cardiogenic syncope. B. Neurocardiogenic syncope. C. Autonomic neuropathy. Or D. Carotid hypersensitivity. This patient presents with 3 episodes of fainting. She has a long history of Hashimoto thyroiditis, and her TSH is 10. Her poorly controlled hypothyroidism is also evidenced by her dry skin and brittle hair and nails. Although the resting ECG is normal, her resting heart rate is 48 beats per minute. In other words, she has a sinus bradycardia likely due to hypothyroidism. Sinus bradycardia decreases cardiac output and cerebral perfusion, resulting in syncope. Therefore, the most likely cause of occasional loss of consciousness in this patient is option A, cardiogenic syncope. Here we see the different types of bradyarrhythmias that can cause syncope. Let's discuss why other options are incorrect. Option B, neurocardiogenic or vasovagal syncope, is incorrect because this patient's fainting episodes have no precipitating factor, unlike vasovagal syncope, which is triggered by stress or prolonged standing. Option C, autonomic neuropathy, is incorrect because this patient has a very short-term history of diabetes mellitus. Additionally, standing up causes the normal hemodynamic changes in this patient, suggesting that her autonomic nervous system functions normally. Finally, option D, carotid hypersensitivity, is incorrect because this patient's fainting episodes are not triggered by external pressure on the carotid sinus. And that concludes our lecture on syncope.